Good afternoon, everyone, and welcome. My name is Dr. Brewington, occupational therapist with the Occupational Therapy Department here at SUNY Downstate, and I'm honored to welcome you to our annual Interprofessional Clinical Case Study event. Thank you. I'd first like to thank our students, faculty, and facilitators and guests for being here today and for taking part in this important learning experience. It's always inspiring to see so many disciplines come together in one place with shared commitment to learning, collaboration, and patient-centered care. One of the most important things our students can learn from our future healthcare professionals is that excellent care does not happen in isolation. In real practice, the best outcomes are often achieved when professionals from different disciplines come together, communicate effectively, respect each other's expertise, and work collaboratively to support the whole patient. This is exactly what today is designed to highlight. This event gives students the opportunity to step into a clinical scenario, apply the knowledge and perspective of their own profession, and at the same time, learn from the viewpoints of each other. It is through these shared experiences that students begin to better understand professional roles, strengthen clinical reasoning, and build the communication and teamwork skills that are essential in today's healthcare environment. The goal of today is not only to work through a case, but to truly engage in the process of interprofessional learning, listening, contributing, problem solving, and recognizing the value that each discipline brings to patient care. We hope today's experience is both meaningful and impactful, and that it leaves you with a deeper appreciation for the power of collaboration in healthcare. So thank you again for being here. I hope you enjoyed today's event. And I ask Dean Lewis to please come to the podium.
Thank you, Dr. Brewington. Good afternoon, everybody. Good to see so many people. Every year we break a record in terms of our attendance. We have people in the room, I think more than 170. We have people online, 40 or 50, and then some on live stream that we haven't been able to count. So greetings and welcome. Good to see all of you out. This is one of the few events other than convocation and commencement when we all get together across our silos. Let me just tell you a little bit about the background on this event. So, I've been around for a long time. I worked at 5 institutions, and this is an event I was part of at my first academic institution. It was very, very beneficial to everybody who participated in it, and I decided, I'm a little bit of a hoarder, so I decided to bring it along. So that's what I do. I travel around different institutions, pick up things here and there, and try them in different settings. And so I think this might be our 8th or 9th year doing this in the School of Health Professions. It has grown over those years, and now it's not only the School of Health Professions students, of which we have 8 programs, but it's also College of Nursing and School of Public Health that are involved. So we're making it bigger as we go, bigger and bigger footprint. As you know, an event of this magnitude obviously requires a lot of people to plan it, and I know I'm going to miss somebody, so what I'm going to do is give some general thanks to those who have put this together. It really is a monumental lift to make this happen. And so our chair of our committee, Dr. Brewington, obviously, give her a hand, absolutely. Our new assistant dean, Dr. Vales Lewis, has been instrumental in putting this together. She's back in the back. We also have faculty from public health and nursing who are involved. Of course, we have students from all 3 of the schools involved. We have our program administrators from all the SOHP programs, that many of whom helped get you checked in today. So as you can tell, it takes a cast of thousands to pull this off. And so thanks to everybody who is involved, and of course to you students who are here. So I have, I don't usually read anything because I like to talk off the cuff, but I did write down 5 missions, and some of it Dr. Brewington already captured, but I want to hit it again because it's worth repeating some of it. You all came to Downstate to basically learn one discipline, right? The discipline that you're enrolled in. But we at Downstate try to do things a little differently. We want to give you a little more return on your investment. So we try to give you a little more value-added content. And that's what this type of event is all about. We do some other things too. But this event sort of epitomizes us giving you that additional content that's important to your experience that you probably wouldn't get at another school. So be thankful you came here. We're happy you came. And because you're here, you're getting these additional value-added exposures that you wouldn't get at another school if you were studying your discipline in another accredited program. So that's our goal, to really give you the extra, so that when you go out and you compete against a person in your same discipline from Toro or NYU, you have some things that you can draw upon in terms of your exposure that allows you to say, I'm a little bit better than this person next to me. I mean, we're both trained the same. We're both coming from accredited programs, but I know some other things that person probably wasn't exposed to. So that's what you get here at Downstate. That's what we always endeavor to do, to give you some extra stuff. And I'll put in a plug shamelessly for a course that I'm going to be offering in the fall, a seminar course, very short, half a credit, that's called Beyond Discipline-Based Expertise. So not expertise in your discipline, skills beyond that, so you all can be leading thinkers and influencers in your field. If you want to go out and 10 years from now, be the person who comes up with the next great intervention or whatever it may be in your discipline, you got to have a different set of skills than just what you're learning in your curricula, because you're learning how to be a clinician. But you got to have some broad skills. So I'm encouraging those of you who are not graduating in May or this summer to think about taking that course. I think it's 7 hours that you'll have to take on your own time, asynchronous. But that's another one of those value-added activities you can only get at Downstate. We're going to teach you how to anticipate the future, how to improve your critical thinking, how to build a learning organization, how do you manage change, how do you become a great leader, how do you do business operations, how do you do strategic communications in an organizational setting, how do you build your professional network, those kinds of skills that you're probably not getting much about right now in your clinical disciplines. So I know I'm talking too long, so let me go ahead and read these 5. I know we're on a tight schedule. You know me, I get going and don't know where to stop. So let me read these 5 missions, which are somewhat overlap with what Dr. Brewington said. So the 5 missions of the Interprofessional Education Case Study Event, I'm going to read them so I make sure I don't misstate anything. So number 1, the Interprofessional Education Case Study Event helps students see and understand the delivery of healthcare services, that it happens beyond your own silo and your discipline. Further, it illustrates the cross-discipline collaboration that happens in the real world of healthcare, or it should happen if it's not happening. Number 2, this event exemplifies the teamwork required to address a complex array of challenges in a particular clinical scenario. Thank you, Calvin. Number 3, students learn firsthand the assets of each discipline and how it contributes to a successful healthcare outcome. This event offers an invaluable example of the concept of parity, level playing field, among all healthcare disciplines in terms of importance and the synergy that can be achieved with a collective interprofessional effort. Students should leave this experience with greater appreciation of their own healthcare discipline and the other disciplines on the team that work together in a complementary manner. So I'm encouraging you all to get as much out of this today as you can. Dig in, engage, learn, look, listen, and learn, and enjoy. And with that, I'm going to turn it back over to Dr. Brewington.
Thank you very much. Okay, so we're going to jump into our case study.
Okay, we're going to start with the patient history. Sandra is a 32-year-old math teacher who moved from Jamaica to Brooklyn in 2023. She lives with her partner and 1-year-old in a 2-story walk-up apartment. She teaches at a nearby high school. Her partner often works night shifts. Sandra's medical history is significant for sickle cell disease and a cesarean section for placenta previa with her first pregnancy 1 year prior. Because of a cesarean wound infection, she experienced an extended hospitalization where she was closely monitored on bed rest with antibiotics. During this time, she suffered a pulmonary embolism. Sandra started warfarin therapy, which was discontinued after 90 days because the triggering event of her pulmonary embolism was thought to be surgical complications and bed rest. And people with sickle cell disease are at increased risk for complications when taking anticoagulants. She was referred to see a pulmonologist, And after searching for a provider that was in network with her insurance, she was finally able to get an appointment 6 weeks later.
You're about 6 months postpartum, correct?
Yes, and I had a C-section with complications. I was in a hospital for a while. I even had a blood clot in my lung.
Right. I see that, but you completed your warfarin therapy, and that was related to surgery and bed rest.
Yes, but I still don't feel right. I can't even keep up with my baby.
Recovery after pregnancy and surgery takes time. Deconditioning is very common.
But it's not improving.
I wouldn't jump to more testing right now. There's really not much to do at this point. Try gradually increasing your activity, and your endurance should build back up.
I waited 6 weeks for this appointment and took off of work for this. Okay.
6 weeks later, she presented for a routine annual physical and cervical cancer screening.
Hi, Sandra. I understand you're here for your annual exam, but it seems you've been having some ongoing symptoms?
Yes, I'm still short of breath. It's actually worse. I can't even lift my toddler or do basic things like laundry without stopping.
That's definitely not expected at this stage. Let's go through your history again.
I had a pulmonary embolism after my C-section. I also have sickle cell disease.
Oh, thank you for sharing that. Given your history and persistent symptoms, I'm concerned this may be more than deconditioning.
That's what I've been feeling.
I'm going to do a full physical exam and consult cardiology. We should run more specific tests to evaluate your lung and heart function.
What kind of tests?
Well, we'll likely order imaging to look at blood flow in your lungs and possibly a right heart catheterization to assess pressure in your pulmonary arteries.
Okay, I just want answers.
The provider consulted with the cardiology team in the practice, performed a complete physical examination, and ordered a right heart catheterization and ventilation perfusion scan, which confirmed the diagnosis of chronic thromboembolic pulmonary hypertension. Sandra's history of sickle cell disease was carefully reviewed by the team when anticoagulant medications were considered and prescribed to prevent further clotting. Based on the location of the scar tissue and blood clots in her pulmonary arteries, Sandra was counseled about scheduling a series of balloon pulmonary angioplasty procedures to open the blocked vessels and restore lung perfusion. Over the course of the following 6 months, Sandra underwent 4 BPAs and significant perfusion was restored. Once her symptoms began to improve, she was cleared for evaluation and treatment with physical and occupational therapy.
Okay, we're now going to start with our professional presentations from our disciplines. I'm going to call the students representing diagnostic medical imaging to the panel first, please. I apologize. Hold on. I'm sorry. We're going to start with health informatics. I'm sorry. It's just out of order.
Thanks. All right. Hello, everyone. As spoken, we are the health informatics discipline. This is where all our training goes into work, right? So, all right. So, right now, as the case study stated, we are just examining what the patient was talking about to the provider, and we're going to tell you via our health informatics expertise. So today we are looking at the case study involving lung condition, also called the CTEPH. While this is a medical condition, we are going to examine it through the lens of health informatics. So just a little understanding of health informatics. Health informatics is a focus on how healthcare data is collected, organized, and used to support clinical decisions. In healthcare, we move from raw data to meaningful information, so that helps guide patient care. Our goal today is to show you how using accurate and timely information can help identify conditions earlier and improve patient outcomes. Okay. You change it like this? Case study. I think, yeah, I think this, huh? Oh, got you. Oh, okay, thank you. Okay, so, if you're wondering what health informatics actually does, simply put, we manage and organize healthcare data so it can be used effectively in patient care. This includes systems like electronic health records, but also clinical decision support systems that provide alerts, health information exchanges that allow different hospitals to share patient data, and patient portals where individuals can view their results and communicate with providers. For a patient like Sandra, in this case, these systems can work together to highlight important risk factors like a history of blood clots or sickle cell disease, and flag symptoms such as shortness of breath. By making this information visible and connected across providers, we help improve communication, support faster decision-making, and reduce the risk of missed or delayed diagnoses. Okay. So one of the tools used in health informatics is AI, or artificial intelligence, which helps support clinical decision-making. These systems, often called predictive tools or clinical decision support systems, review patient data and identify patterns or risk factors. They can generate alerts or recommendations based on the patient's history and current symptoms. For the patient like Sandra, this could mean the system recognizes her risk factors and suggests further testing when symptoms like shortness of breath are documented. This helps providers make more informed decisions in a timely manner. And overall, these tools support a more proactive approach to care by helping identify potential issues earlier and improving diagnostic accuracy. I'm Lauren, and I'm going to give it over to Yvonne.
Hi, everyone. I'm Yvonne. All right. First and foremost, I want to know who here has worked with AI in the healthcare setting. Anybody raise your hand? You have? Okay, cool. So for health informatics, it's very important that we use filtering whenever it comes to caring for a patient. So in the situation, for example, we use something called clinical decision tools. The responsibility of those is that they're going to be filtering certain systems alerts. So that can look for looking for keywords, certain phrases, depending on the diagnostics. So with that information, it alerts the system to say, these are the trends to look for whenever you're catering to a certain population or demographics. This is actually a benefit because it flags for the risk of potentials for our case for our patient here who has issues with sickle cell, issues with her pregnancy. So overall, that gives us some type of leadway within health informatics to know how to generally take care of the patient. Something else that we can also use is certain tools that can be triggered off so that it can be streamlined so that we can tell the patient or the clinician exactly how we can go about treating the patient properly. All right, so health-related decision support through informatics. So the first slide, we show a representation of what the EHR, which is the electronic health record, what that looks like. The EHR is responsible for holding organized, structured information so that it's integrated across all platforms. I'm not sure if anybody's familiar with a platform called Epic, but Epic uses an EHR system, and they use also called MyChart, where you can go from one facility that hosts Epic, and then you can go across to another facility, and your information for the patient will be streamlined, and you can do integrations internally, so that's easier accessible for patients, providers to obtain their clinical documents. Also, going back to, again, the process of using certain keywords. That also plays a role in what communities that we're looking for to say if there is a bigger issue or if anything that flags the system to say this is something that can be used for statistics to say we need to help improve the community or anything that will advance them in many areas.
Hi, everyone. I'm Danielle. So to piggyback off what Yvonne was saying just now, so one of our goals is to have early detection, and we do that through these systems. So one of the things we would do is identify health risk priorities early on. So like our patient, she has sickle cell disease, she's had previous issues and complications with her pregnancy. The system would log that away and bring that up when she's going for her appointments. And so one of the things that we will also do is integrate this into remote monitoring. So we would integrate this into prenatal and postnatal care and postpartum care so that the patient has accurate information to go off of, and the provider also sees these things and it will flag it so that the testing will be done, and also helps to standardize this type of testing early on to help the patient and the provider understand what's going on. And it also helps as a monitoring system for other patients as well. So if this patient has an issue, the system can take that and suggest like, hey, this we see a trend, and this patient might be at risk for certain types of diseases, and diseases or comorbidities, and that's really what the CDS tools help us to do, and we use this to help support multiple disciplines within the clinical setting.
Hi, everyone. I'm Natalia. And just to tie all of that in, how would this help our patient at hand? How would this help Sandra? Sandra was not seen when she was supposed to be seen. She was not taking the test that she needed. And from a health informatics point of view, the CDS alerts can help bring all her information and data, not only from her, but from her same patient population, that would raise flags to her clinicians about what needs to be done. And then we have AI in healthcare that can suggest different medications to the provider, and it could be very, very tailored towards our patient. And it's things like telehealth monitoring that can reach out to Sandra, that can have her have an appointment without waiting 6 weeks, because she waited 6 weeks for her first appointment. And if she had telehealth, she can see a doctor face to face without having to have so much transportation and wasting gas, and she'll be able to have her baby around her. All of that can be a substantial change in what her healthcare looks like. And all the automated recommendations that can be seen in the CDS and the, seen in the CDS and in the EHR system can continuously update, and she could be able to contact her providers more easily using the health informatic tools that are provided. And these are our references, and we thank you so much for coming.
Great. Thank you. Next, we're going to have our students from the Physician Assistant Program. If you can come up, please.
Good afternoon. Today we're going to be presenting on behalf of the PA program. My name is Catherine.
My name is Amy.
My name is Eugene.
And today we're going to start off by talking to you a little bit about who physician assistants are and what our role is in healthcare. So, who are physician assistants? Physician assistants, also called physician associates, are nationally certified and state licensed clinicians who practice medicine in every specialty and setting. So what's special about PAs is that we have lateral mobility, meaning that we can transition across multiple medical specialties throughout our careers. And this allows us to work in multiple specialties if we so choose. We are trusted because we undergo a very rigorous education and we are trained healthcare professionals. PAs are dedicated to expanding access to care and transforming health and wellness through patient-centered, team-based medical practice. So again, what is our role in healthcare? Specific duties depend on the setting which we work in, our level of experience, the specialties we're working in, and state laws and regulations. So in terms of what kind of patients can PAs manage, we can manage patients of all ages, including pregnant women, non-pregnant women, males, children, elderly, really anyone at all. And when we talk about working up a patient, we start with a comprehensive history and a physical exam, including vital signs. So things like blood pressure, heart rate, temperature, etc. And we can start to develop our differential diagnoses based on the presentation of the patient, their chief complaints, signs and symptoms, and things like that. And then we can move into ordering and interpreting diagnostic tests. So things like labs, blood work, imaging, and this really helps us to narrow down what we think the patient may have. And then we can start looking into treatment plans. So treatment can look very different for each individual patient. So we are able to prescribe medications, including Schedule 2 to 5 drugs, which are essentially controlled substances. We can also refer patients to other practitioners and other healthcare providers to best manage and care for the patient in a collaborative way. And a big part of treatment is actually educating the patient, giving them resources and reading material to help them best understand their condition. And lastly, PAs are able to perform procedures, assist in surgery, make rounds in hospitals and nursing homes, and do clinical research. So now I'm going to pass it to Eugene, and he's going to talk to you guys about the case.
Okay, so first of all, I would like to discuss the pertinent case information that was just played out here. So we have a presentation of 32-year-old female, postpartum C-section, shortly after which she had extended bed rest, and she was diagnosed with the PE. She was successfully managed for 2 months with the warfarin. The symptoms initially resolved, however, later on, she discovered that symptoms returned. The exertional intolerance started creeping, and it started getting worse and worse. So initially, it was misattributed to deconditioning, as was nicely played out. And later on, after she returned back for her regular checkup, finally, the cardiology team workup was done with the VQ scan mismatched and the right heart catheterization, yielded diagnosis of the pulmonary hypertension and the chronic thromboembolic pulmonary hypertension condition. The management in her case was discussed and was agreed upon anticoagulation, as well as the non-invasive balloon pulmonary angioplasty, which significantly improved her perfusion. And why this case is significant? This disease condition is not well known, and we should have a high sense of suspicion of patients who present initially with PE that is successfully resolved. However, they would come back and they would start complaining of essentially dyspnea or non-specific vague symptoms. And we really need to have our ears up and make sure that we are not dealing with this kind of condition. So on my next slide, I would like to talk a little bit what this condition really is about. The chronic thromboembolic pulmonary hypertension, etiology itself is not well understood. All we know for sure is that it's a long-term complication of the pulmonary embolism, that basically what happens is we believe that there is a constant creation of the thrombi which do not resolve, and they accumulate, and this creates the pressure obstruction that becomes eventually pulmonary hypertension. As I mentioned before, symptoms usually presentation is unspecific, and the only symptom that you really have to pay attention to and start thinking is really progressive exertional dyspnea. Like in our case, the mom complained that she out of a sudden discovered that she has a problem with handling her kid or doing any day-to-day activities. So What's also important is usually it's the on the research they mentioned that it's after the pulmonary treatment of the with anticoagulation, and this also might be a clue. Now, why? Now, the good news about this condition is that if it's caught early, it's actually pretty curable. And however, the lifelong coagulation is usually necessary. The cure can be invasive or uninvasive. The invasive with the basically pulmonary thrombectomy, non-invasive with the balloon pulmonary angioplasty. So in the patient's case, Sandra case, so what are the history that we should have noticed in order to suspect this condition? Again, very important, dyspnea, fatigue, exertional intolerance. Those are the clues. But I think the most important clues is prior PE and anticoagulation therapy. They believe that essentially this condition is already present from birth, but we need a PE to trigger that. So that's why a PE is the clue. And the PE usually resolves at first, but then the symptoms return and they worsen. That's also important clinical picture. And in addition, there's a risk factors that was already found out. It's usually surgery, immobilization, postpartum state, and the sickle cell disease that coincidentally our patient, all of these risk factors was having. So now I would like to ask Amy to continue the presentation.
All right, thank you, Eugene, for discussing some of the pertinent case information and Sandra's past medical history. I will now discuss the PA's role in diagnosing and managing CTEPH. First, we would begin with the physical exam. We would start with inspection, where we would see pedal edema, JVD, breathlessness, and signs of hypoxia such as cyanosis. All those can also indicate right ventricular failure. After inspection, we will move on to palpation and percussion. Here we would see an enlarged liver, some fluid in the abdomen, and again, that pitting edema. The last part of our physical exam is going to be auscultation, or listening with our stethoscope. Here we would hear some abnormal heart sounds, such as an accentuated second heart sound, as well as a high-pitched sound over the lung field called a bruit upon inspiration and while holding our breath. All right, as Catherine mentioned earlier, PAs are able to diagnose patients. For Sandra's condition, we would start off by ordering some basic lab tests. This can include our CBC, our CMP, then we're looking at the BMP for heart function and some other clotting factors. PAs are also able to perform and interpret some diagnostic tests and imaging, and this is a great opportunity for us to work alongside some other healthcare professionals. These tests can include EKGs, echocardiograms, chest x-rays, CT, VQ scans, and so much more. Then, the gold standard for diagnosing Sandra's condition is going to be the right heart catheterization with conventional pulmonary angiography. This just measures the pressures in the heart and the pulmonary artery. Listed below is the specific diagnostic criteria that we as PAs would have to know. After diagnosis, we want to go ahead and treat Sandra's condition. As PAs, we're able to prescribe medications. For Sandra's case, we would start off with prescribing her some lifelong anticoagulant medications. This will help to prevent any other clots from forming. We can also prescribe her diuretics and supplemental oxygen to help alleviate any of her other symptoms. PAs are also able to assist in surgery. In Sandra's case, she received a BPA, and this helped to open up the blood vessels and restore perfusion to the lungs. Lastly, we want to help Sandra feel confident in living with and managing her condition, so we would go ahead and provide patient education. This will focus specifically on medication adherence. We'd help her manage any other conditions she may have, such as sickle cell disease, and we'd make sure she uses anticoagulants and wears any compression stockings during any prolonged hospital stay. This is again to help prevent clot formation. Overall, this is the PA's role in diagnosing and managing CTEPH. Thank you so much for your time.
Thank you very much. Next, we're going to have the students from the midwifery department please come up. midwifery program.
There we go.
Hi, everybody. My name is Madeline. This is also my colleague.
Good afternoon, everybody. My name is Amali.
And we're representing the midwifery profession. We are a tiny but mighty cohort, but we are here to talk a little bit about what midwives, their scope of practice, and what they would be involved in this patient's care. Okay, so we can start with the basics. What is a midwife? We are independent practitioners. We do care for women with female reproductive organs, and we can support them throughout their lifespan, anytime from when they first get their period all the way past menopause. So we can be both a primary care provider and then, of course, reproductive health care. We can do not just birth, which I feel like a lot of people that's what you think of when you think of midwives, but if you need contraception, if you need cancer screenings, right, breast cancer, cervical cancer, we can do all of that. And then of course we can do primary care, so your annual visit, as well as your annual gynecology visit, that is also us. We do try to be more patient-centered. We're really focusing on how to make the patient's life better and improve those life qualities. We can provide care both in the hospital, in clinics, in birth centers, if you're not trying to give birth in a hospital. Also, if you would like to labor at home and give birth at home, we are also able to provide care in that aspect as well. As I said before, we can provide care throughout the lifespan, and then typically people will choose a midwife because they're looking for more well-rounded care, whole person care, right? So we're trying to make sure that we're connecting you with any community organizations or hospital organizations, even if you have any questions about your insurance or patient adherence or medication adherence, we can also connect you with those services. Okay, so we're just gonna break down when a midwife would see Sandra. In this case, there are 3 separate occasions. The first one is gonna be her 6-month postpartum visit, and then a routine physical exam and cervical cytology screening. That's gonna be like your annual checkup. And then also we are going to be focusing on preventing readmission after her BPAs.
Okay, so we're going to start with what management looks like in terms of her postpartum visit after 6 months after giving birth, which in this case would be considered a follow-up or a primary care visit. So we would start off with gathering a very thorough history and documenting ongoing fatigue, the shortness of breath, and functional limitations that she might be experiencing. Then we would go into assessing, right? So we would be doing a head-to-toe physical exam, checking vitals and her functional status. Then we also like to emphasize or focus our work on advocacy. So recognizing that her symptoms are beyond what is normal for the postpartum period, and then obviously referring her out. We also like to focus our efforts on education. So educating on the warning signs for anything that might be worsening related to her condition, her cardiac status, and what is considered safe for where she is in her postpartum journey. And then finally, we would be focusing our efforts also on the coordination, so helping with appointment scheduling, if she has any barriers around navigation or transportation to her appointments, and ensuring that we do get her back, right? We want to be able to follow up with her. Annual physical. Okay, so for management during your annual physical, that's also a time where we would be doing cervical cytology culture and getting a full picture on how she's doing in terms of her gynecological health. So again, we would be gathering history, detailed history on her symptoms, any complaints that she has that are ongoing. We like to really try to focus on that because we're not experts and we also don't live in your body. So what you feel is very true and we want to honor that. And then we will also be sure to do a head-to-toe review of systems. And then for examination, we would do a head-to-toe physical examination, including a cardiopulmonary assessment and a pap smear. So we will be taking some cultures to see how your vaginal health is looking like. And then in terms of our judgment or advocacy, we would try to focus our efforts on identifying the need for further testing, or if we need to refer out and have to consult cardiology. And then finally, the support for Sandra would be to explain why these tests are necessary and reassure her that her concerns are valid, right? And then we believe in preventative measures. So we want to avoid you, or in this case, our patient having to be readmitted into the hospital. So coordination for that would look like bridging between the multidisciplinary teams and the patient. We want you to also feel empowered. It's your story, it's your body, so we want you to be in on the conversation. Education, so we want to educate her on the anticoagulation medication that she is on. We want to educate her on anything that is outside of her norm. So if she's getting worse, if she's bleeding, and what we deem safe during this period. Monitoring and support. So we also want to track your symptoms, and the progression of recovery from the BPAs. And then finally, we want to make sure that your emotional and your mental health are stable as possible. So we're going to address the fatigue that you're feeling, any frustrations or anxieties that are related to the chronic illness that she's experiencing, and also the stressors of being a parent for the first time, which is also really real and valid.
These are just a couple of access and advocacy considerations that we as midwives think of, just so that we're making sure we're taking care of the entire person and not necessarily just an amalgamation of their symptoms, right? So trauma-informed care and communication. This patient has had an experience where they came in and they said, this is what's happening in my body, and the person who was treating them said, no, it's not. That's a problem. So when we talk to this patient, we need to make sure that we're trusting them, that when you say that your symptoms are happening, I believe that they're happening, and so we're going to get you the care that you actually need. Screening for social determinants of health that may affect your recovery. She lives in a walk-up, she has a child. We don't necessarily know what her income level is, but these are all things that are really important in determining this person's recovery and making sure that they have everything that they need. Postpartum mental health screening and referrals as needed. It's something it's often not talked about, so it's something that we have to bring up to our patients. This is normal, this is something that we can help you with. We have the resources to help you with this. So we just wanna be really proactive in providing that to our patients. Chronic disease self-management programs, we can absolutely connect them with that, especially if you work in a hospital. And we do try to be really collaborative and multidisciplinary, like making sure that we're talking to other disciplines. Yep, there you go. And so we just want to make sure that they have access to those programs so that they are taking their medication properly and they're managing their health on their own, that they're capable of doing that. And then in case they have any problems with their insurance, we can also connect them with any insurance navigation support, especially if you're in a hospital, but making sure that you have those resources for those who work outside of hospitals is also super important. And that's it.
Thank you very much. Next, we're going to have our students from the Diagnostic Medical Sonography program please come up.
Just press the large button in the middle to.
Hello, good afternoon, everyone. My name is Charmine. This is Dora. We're representing the Diagnostic Medical Imaging Program, also known as sonography. So as you already know, we're going to talk about CTEPH, yes. All right, so this case, as you guys already know, as a reminder, it involves a 32-year-old woman with 6 months postpartum and is experiencing persistent fatigue and shortness of breath with minimal exertion. Her medical history was significant for sickle cell disease with cesarean section performed due to placenta previa. After surgery, she developed a postoperative post-operative infection, which required an extended hospitalization and prolonged bed rest. During hospitalization, she developed a pulmonary embolism, which was treated with anticoagulation therapy. However, even though after treatment and recovery from surgery, she continued to experience symptoms including shortness of breath and normal daily activities. I reread the case because this is sort of a mini lesson that we're kind of doing in regards to sonography. So, pregnancy and postpartum period creates a physiologic, apologies guys, hypercoagulability state, meaning that blood becomes more prone to clotting. This occurs because the body increases clotting factors in order to prevent excessive bleeding during and after childbirth. However, this protective mechanism also increases the risk of venous thromboembolism, which includes deep vein thrombosis and pulmonary embolism. The image shown on the slide represents the virtuous triad, which explains three major factors that contribute to clot formation and which is hypercoagulability, endothelial injury, and venous stasis. In this patient, multiple factors contributed to each part of the virtuous triad, such as cesarean delivery causing surgical trauma, post-operative infection causing inflammation, and prolonged immobilization during hospitalization, which led to venous stasis. In addition to the patient's history of having sickle cell disease, which increasing the risk of clots. So together, these factors contributed to the development of her pulmonary embolism. All right, so in CTEPH, there's chronic thromboembolic pulmonary hypertension that develops within the pulmonary emboli and do not completely dissolve after the initial event. The clots become organized scar tissue that partially obstructs the pulmonary arteries. This obstruction increases pulmonary vascular resistance, meaning that the right ventricle must work harder to push blood through the lungs. As a result, the pressure within the pulmonary arteries increase, which places significant stress on the right side of the heart. Over time, the right ventricle must pump against this increased resistance, which can lead to right ventricular dilation, reduced contractility, and eventually right-sided heart failure if untreated. Because of these changes, these can develop gradually. Patients may present with persistent shortness of breath, fatigue, exercise intolerance, which were the symptoms present in this patient. All right, I have to stand up. Okay, so it was important to put that background because that's some of the knowledge that sonographers need to know to perform an ultrasound to understand the different pathologies. So sonographers are a key role in the initial evaluation of the heart structure and function using ultrasound. Specifically for the heart ultrasound, it's called echocardiography. Echocardiography allows us to assess the heart chamber size and function, and it evaluates blood flow using Doppler ultrasound, and it identifies signs of abnormal pressures within the heart. In suspected pulmonary hypertension and right-sided heart disease, it focuses on the right ventricle, looks for changes in the heart shape and movement, and it identifies indirect signs of increased pressure in the lungs. In this case, echocardiography helps detect right heart strains associated with CTEPH. All right.
So, echocardiography is one of the most important non-invasive tools used to evaluate patients with suspected pulmonary embolism. It allows us to assess right heart anatomy and structures, structural changes caused by increased pulmonary pressures. One key finding is right ventricular dilation. When pulmonary artery pressure increases, the right ventricle must pump against great resistance, which can cause the chamber to enlarge. Another important sign is interventricular septal flattening, which produces the appearance of a D-shaped left ventricle in the parasternal short axis view. If we look at the two images on this slide, the one on the top is a normal heart parasternal short axis view of the heart. You can see the right ventricle on the top. If you compare the right ventricle on the top with the right ventricle at the bottom, you can see a big difference showing an enlargement of this right ventricle. If we look at where the red arrow is with the image on the bottom, we can tell that that's actually the interventricular septum. It is bulging because the pressure in the right ventricle is extremely high due to volume overload, and it's pushing it, creating a D shape or a flattening shape. So this occurs because increased pressure, like I've said, in the right ventricle pushes it. Additional structural findings may include right atrial enlargement and dilation of the inferior vena cava, which indicates elevated right-sided pressures. So as the pressure in the right ventricle continues to increase and there's constant right ventricular overload, it's going to start to back up into the right atrium. Also, blood going into the pulmonary arteries, it's also going to have an increased pressure due to also the pulmonary embolism that our patient Chandra has. Together, all these findings strongly suggest pulmonary hypertension and right heart strain. In addition to visual structural changes, echocardiography also provides quantitative measurements that help estimate pulmonary pressures and elevate right ventricular function. One key measurement is tricuspid regurgitation velocity, which is obtained using Doppler ultrasound. The velocity of the tricuspid regurgitation jet can be used to estimate right ventricular systolic pressure, which closely reflects pulmonary artery pressure. The velocity, this calculation is based on the modified Bernoulli equation, where right ventricular systolic pressure equals 4 times the square of the tricuspid regurgitation velocity plus the estimated right atrial pressure. Another important measurement is TAPSE, which stands for tricuspid annular plane systolic excursion. TAPSE evaluates the longitudinal contraction of the right ventricle, and reduced values indicate impaired right ventricular systolic function. So with TAPSE, we get to know how well the right ventricle is pumping. Once there's going to be an overload on the right ventricle, you will notice that the muscles of the right ventricle will give up. It will not be able to squeeze to push enough blood out of it, and then this will lead to an overload backing up into the right atrium. We also evaluate inferior vena cava diameter and its collapse with respiration, which helps estimate right atrial pressure. So when we scan the patient, we will ask the patient to take in a deep breath. If the inferior vena cava cannot collapse more than 50%, it means that there is a problem. But if the patient, when the patient takes in the deep breath and the IVC can collapse more than 50%, it means that there is no pulmonary embolism. But with Shonda, we believe that she would not be able to collapse her IVC more than 50% due to the right-sided strain and the right-sided pulmonary embolism and the right-sided problems that she has. In conclusion, this case demonstrates how unresolved pulmonary embolism can progress to chronic thromboembolic pulmonary hypertension, leading to increased pulmonary artery pressure and right heart strain. Echocardiography plays a critical role in evaluating these patients by identifying structural changes such as right ventricular dilation and septal flattening, as well as providing Doppler measurements that estimate pulmonary pressures and assess right ventricular function. Early recognition of these findings allow clinicians to pursue additional diagnostic testing, initiate appropriate treatment such as the balloon pulmonary angioplasty, which can resolve pulmonary blood flow and improve symptoms. Thank you.
Thank you. Next, we're going to have our students from the occupational therapy program. Please come to the stage.
Hi, everybody. I'm Andy, and I'm from the occupational therapy department, and we have Jenny and Danielle. So we're going to start with the role of occupational therapy. So the primary role of OT services for Sandra is going to get her back to functional engagement in her occupations. So occupational therapists, a little different from some of the other folks here, we're using what's called a top-down approach. So we're really looking at the sorts of activities that are meaningful and important to her or her occupations and getting her back to doing those before we develop the different interventions to get her to that point. So the first thing we would do is develop something called an occupational profile. So that's looking at all the information that the other groups were just talking about and collecting that along with her Sandra's occupational history, experience, interests, values, etc., to really develop a profile of her. And we'll talk a little bit next about how we do that. And that will get us focusing on activities of daily living, ADLs, and instrumental activities of daily living, IADLs. So we're starting with the ADLs because that's what's going to allow her to live independently. So ADLs include bathing, toileting, dressing, feeding, functional mobility, and grooming. And IADLs would be caring for others, in this case, her child, communication, getting to work, so community mobility, meal preparation, home management, and financial management, and anything else in that area. So to start, we're going to do an evaluation of Sandra. So the evaluation can be done by reviewing her medical history, like I said, everything that was presented. It could be informal interviews, just talking to her, seeing what's important to her, also monitoring how she's responding when we're asking questions, etc. We could do a home assessment. Danielle's later is going to talk a little bit about that. And then there's some standardized assessments we would like to employ with her. So the first one, which I have a screenshot of on the right, is called the Canadian Occupational Performance Measure, or the COPM. This is where Sandra would select activities that are important to her that she's currently struggling with because of her conditions, and she would rank her current performance and satisfaction with her performance in that. So I talked about the occupational profile earlier. This is how we really understand what she's trying to do and how she feels about how she's performing right now. We could do a PASS assessment, performance assessment of self-care skills, which this would be an assessment of specific activities that she's chosen. So it could be, say, cooking, and there would be a scoring sheet for how she functions in each aspect of cooking, be it motor function, cognition, etc. There's the Borg rating of perceived exertion scale, which is important for her in particular because of the dyspnea. So this, we would ask her to provide how she's feeling in terms of breathlessness and fatigue during physical activity. Once we establish that baseline, we could see if we improve as we perform our different interventions on her. And the last one we'd want to focus on is called the Montreal Cognitive Assessment, or MOCA. And this assesses cognition because we're focusing on that as well. And the reason we would do that is because she had that long hospital stay. She may have some brain fog from her different conditions. So we want to see where she is, not just with her motor skills, but also with her cognition.
So occupational therapists operate under our professions framework, which outlines the process that we would use when working with our client and also different domains that we should consider in order to get the most holistic view of our client and incorporate that into our treatment and plan of care. So first we have context, and context can be broken down into personal context and environmental context. And it's just
talking about who she is outside of the medical perspective. So we know that she's a 32-year-old math teacher, and she moved from Jamaica to Brooklyn. In her environment, these are things that can either support her occupational performance or hinder her occupational performance. So we know that she lives with her partner and 1-year-old in a 2-story walk-up apartment. And then it's also important to consider that she had a long hospital stay and that was her environment for a while. The next domain would be client factors, and this is more talking about, her medical history. So shortness of breath due to sickle cell disease and a pulmonary embolism, which eventually led to her diagnosis of chronic thromboembolic pulmonary hypertension. And then we would also look at performance skills. So within performance skills, we have motor skills, process skills, and social interaction skills. And it's really just breaking down the activities that she's engaging in, looking at specifically like what ways do you have to move your body, or how is she planning or sequencing her occupations. And from this domain, we know that she is not able to sustain engagement in her occupations for a long time due to fatigue and shortness of breath that she gets from, for example, going on short walks, lifting her toddler, or folding laundry. But for a more comprehensive view of her performance skills, we would definitely have to conduct a full evaluation with the COPAM and the PASS that Andy mentioned, and see if she has difficulties in any other areas as well. And lastly, performance patterns. So performance patterns refers to the specific roles, habits, routines, and rituals that Sandra would be engaging in her occupations that make her occupational performance unique to her. And these things would also have to be determined, again, with like a full evaluation with the OT. So some interventions that OTs can work on with Sandra. First, we would most likely teach and train her in breathing exercises. So these consist of pursed lip breathing and diaphragmatic breathing, which both promote the most efficient method of breathing and can reduce that shortness of breath for her. So pursed lip breathing slows down the rate of breathing, activates the parasympathetic nervous system, and allows the lungs to stay open for longer. And diaphragmatic breathing is really promoting the use of the proper musculature, because a lot of people can unconsciously use accessory muscles in the neck and the shoulders when breathing, and that's very inefficient and can cause shortness of breath quicker. OTs can also provide energy conservation techniques. So this includes taking frequent rest breaks as she's doing her activities. It's important to emphasize that rest breaks should be taken proactively before fatigue starts to set in and not after. And then also during these rest breaks, we would recommend that she practices those breathing exercises that we taught her. And the OT can also work with Sandra to prioritize essential tasks in her day and try to do them earlier when she has the most energy. And then we would also work with her to adjust her occupational performance by promoting the most efficient body mechanics. So for example, performing her activities while seated where she can, and reducing large movements like bending or reaching. And we can do this with like maybe changing up the setup of the environment or introducing some adaptive equipment. Lastly, we could also work on therapeutic activities with Sandra. So therapeutic activities simulate occupations that are challenging for her and that she thinks that she needs to improve in, and it leads to functional improvement. So for example, we could work on laundry or cooking or whatever other occupations, ADLs, that she thinks are most important to her and that she wants to improve on. And then these activities can be done in standing to build up her standing tolerance. But of course, we would also consider Sandra's perceived exertion and either grade up or down these activities.
Okay, so for Sandra, her home and work environment plays a significant role in her ability to participate in her daily activities safely. And due to her shortness of breath and fatigue, even modified tasks and routines can become physically demanding for her. And so occupational therapists can recommend different environmental modifications that Sandra can implement in her home and her work environment to help reduce some of that burden. And so in her home environment, we would recommend strategies that can limit unnecessary exertion. And this may include organizing frequently used materials, making sure that they're within easy reach to reduce bending and reaching, and also using adaptive equipment such as a laundry cart to avoid carrying around heavy loads. And then to support engagement in her childcare activities, modifications such as a rolling cart infant changing station can help reduce the need to carry her child around her home and supplies. And then in the bathroom, adding in a shower chair, grab bar, and a long-handled shower head can not only improve her safety, but also reduce fatigue while bathing. Additionally, Sandra lives in a 2-story walk-up, which we all know, and this presents as a significant barrier. And yes, occupational therapists can recommend Sandra into looking into more accessible housing, but our main focus is to emphasize strategies that Sandra can implement into her home environment currently. And these strategies can include setting up essential items on one floor, and then also planning tasks to limit the number of trips up and down the stairs, and scheduling activities to conserve energy. In her work environment as a teacher, we would focus on modifying the classroom setup to reduce the physical demands of being a teacher. And this includes organizing materials, again, making sure that they're within easy reach, and then optimizing the layout of the desks and chairs to minimize any unnecessary movement, encouraging the use of a chair or stool during instruction so she's not standing the entire time, and then incorporating scheduled rest breaks throughout the day to support her participation as a teacher. And thank you.
Thank you. Thank you. Next, we're going to have our students from the physical therapy department. Please come up. Physical therapy program. Forgive me. I'm working on my words. 318.
Hi, everyone. My name is Miranda.
I'm Dan. I'm Chad.
And Joe.
And contrary to what some may believe, just a little summary, PTs don't stand for pain and torture. We are actually movement experts, okay? We help people all aspects of like the health spectrum, from acute to inpatient to outpatient. This case is outpatient. And our main goals are to restore movement, educate, advocate, and most importantly, regain independence for our patients, bring them to a better quality of life than what they may have been before. In this case, we are talking about the pulmonary hypertension. So, Dan?
So this is an incredibly complex case, and it involves a number of factors here. We've had to do very precise imaging. We've had to do some differential diagnosis. We've had to look at the patient's potential deconditioning versus other factors and learn a lot of things. We stand on the shoulders of giants here. We have built the blueprint for a beautiful 747 to fly us on the route to recovery. Somebody's still got to fly the damn thing. So that's where PTs come in. What we're going to do is we're going to look at what is happening here. We've been medically cleared by the doctors to assess the situation, and now we're going to look at the various factors limiting this patient and steer them through each one as they go through this situation. So we're going to look at the various systems. For pulmonary, we might use something like an incentive spirometer to measure exactly how much their vital capacity with their inspiratory and expiratory volume is. We're going to look at things like the modified Naughton scale, which is a measure of the rating of perceived exertion, as mentioned by our OTs. A great outcome measure to look at the cardiac, pulmonary, and other associated systems as a functional outcome for this patient would be the 6-minute walk test here, where we're just going to have them see how far they can walk, more or less. It's more complicated than that, but we're looking for the functional goals and limitations for this patient to understand exactly how far we can challenge them without overwhelming them in each of these categories. And my associates will tell you a little bit more about how we'll steer through each of those.
Yeah, so now the bread and butter of PT. The bread and butter of PT, it's all the interventions that we're going to do. So we've picked a few to kind of the important ones: pulmonary optimization, endurance, strength, and functional exercise.
With the breathing and pulmonary optimization, we'd focus on lateral costal breathing. My fellow OTs kind of went into it a little, but basically, this one is a little different because we'd cue them on the sides and tell them blow up a really big balloon or blow up like you're an accordion. And that will hopefully, not hopefully, but it will ventilate the underventilated areas in the lungs that are usually not used, especially in patients of this type of case. We would also include thoracic mobility in this as well to really open up the chest wall so that we allow for more expansion, because when you're breathing in, this has to open up, right? And then from there, we would combine that with core, and we would include transverse abdominis training to really help facilitate intra-abdominal pressure, which not only helps with her pelvic floor muscles, since she did have a cesarean section a year ago, but it will help create proper pressure in the abdomen for her breathing efficiency. From there, building on the whole breathing and everything, we've got endurance. We'll do aerobic exercises, so treadmill, the UBE bike, the arm bike and everything. We'll try to do that as well. Start off in like 5 to 10 minutes and hopefully improve from there. Assessing and monitoring, as Joe is going to talk about. And then from there, we're going to do strength and functional exercises together. And Joe is going to demonstrate some of these. So we are really big on focusing on what the patient does at home or in work and life and everything. And then from there, we create our intervention. So our patient, she needs a lot of help with picking up her child. Joe, can you demonstrate a squat press? So this is great because she'll be picking up her child, picking up things from the floor, like teaching and everything. And then from there, we're going to talk about she has a 2-story walk up. Joe, can you show us walking lunges? Great. Can you go lower? Thank you. That's good. And then from there, she lives in Brooklyn. Everyone's walking here, we're all carrying stuff. So we need to do farmer carries. We're going to have her have weights on the side, and she's just going to walk and walk and walk. And then from there, hopefully she will improve, and every week or so we'll add maybe 5-10 pounds, assessing how she's doing. And yeah, she'll be improving in quality of life outside of the interventions that we do in the clinic.
Okay, so talking about monitoring the patient, there's a couple ways in outpatient that we do to monitor. 2 of the main ways would be in terms of vitals, which are the blood pressure and pulse oximeter. We want to make sure that her blood pressure is within normal ranges, because if she is on the higher end, we don't want to risk having a stroke or any type of adverse event. The pulse oximeter, I want to make sure that she's within her normal ranges so that we know that she's getting enough perfusion to her muscles during exercise. On the bottom here is our dehydration scale. We also want to make sure that she is well hydrated, not going to pass out, faint, or anything like that. And then, as OT mentioned before, we have our Borg RPE scale and our subjective RPE scale. So for the Borg, it's in derivatives for heart rate. So each number here is going to be your heart rate times 10. So if it's the easiest number here, so 6 times 10 would be 60. It's the easiest exercise that you can do. And 20 would be 200 beats per minute, which is, you're going way too hard. So we want to try to keep the RPE within about 14 to 16 for good hard exercises. A way that we can kind of monitor it ourselves is doing something called the talk test. So if while she's doing her exercises, we have her try to hold a conversation with her. If she's gasping for breath during the exercise, then you know she's probably going a little bit too hard. But if she's able to hold a good conversation with you during the exercises, then it's probably good enough for where it is. For our regular RP, this would be her subjective analysis of how hard she's going. We don't want it to be too hard in the 10 range. You want to keep it less than 8 is probably optimal for her, within like moderate to vigorous activity. Beyond that, so Dan mentioned one of our outcome measures being the 6-minute walk test. That is one of the primary outcome measures that we'll use. We could also use general outcome measures like manual muscle testing for strength, range of motion, for joint ranges. And yeah, that's about it.
All right. So when we think about goals for exercise intervention, there's a couple principles that we've already went over in some detail. First, you want to improve the hemodynamics, which is basically the ability of the blood to circulate. And this will help to decrease the blood vessel tone, improve the overall oxygen utilization capacity. Muscle strength is very important. A stronger muscle is more adept at utilizing oxygen. So it's important that she is able to do that also to carry over into her quality of life. and other functional activities. We want to improve her dyspnea on exertion. She's a young 32-year-old woman. She needs to be out and moving in life, so she cannot be short of breath doing regular activities throughout her daily life. And again, improving quality of life. That's like the big picture. So mechanisms, we're going to use low to moderate intensity exercise. Some studies suggest keeping the heart rate within 60 to 80% of their heart rate max or heart rate reserve. Some suggest keeping it within at or below 120 beats per minute for heart rate. But overall, we just want to make sure that she is staying within a safe range for progression. Considering her comorbidities as well with sickle cell, she's also going to have some fatigue as well early on, and that's probably going to be long-standing. So it's important to definitely keep it on the low, moderate end throughout this intervention. These will all basically improve the endothelial function, which is basically the blood vessels, making sure that they're low in tone, nitric oxide for vasodilation, right ventricular efficiency. This is all going to decrease the vascular resistance and improve her capacity for work. Some training focuses, as we outlined, include walking, cycling, resistance training. If we're staying in that low to moderate range, we want to make sure she's around like 60 to 70% of her 1 rep max, or the amount of effort she can put for 100%. And anywhere from 2 to 3 sets of 8 to 15 repetitions could be good for that. Just an example. Breathing exercises, as we outlined here. Incentive spirometry is good. However, it improves the aeration to the lung lobes, but it does not train the diaphragm, which is skeletal muscle. So that also needs to be trained with inspiratory muscle trainers, flutter devices, other things like that. Core stability is great. Pacing, again, since she has sickle cell disease, that's going to be a barrier to her ability to continue doing work for long periods of time. So it's important to have her rest regularly throughout the interventions to make sure she's not gassing herself out too quickly. And submaximal training is basically low to moderate exercise. Functional targets, we want to make sure she's able to lift 25 pounds. She has a growing child. She's going to need to play all day, as children do. So you want to make sure that she is able to handle, childcare and just regular responsibilities that come with being a parent. Climb 2 flights of stairs. She's trying to go back to returning to work as a math teacher. She's going to be up and down. She needs to be able to adequately handle those demands. Improve standing and stair tolerance. Again, thinking about return to work capabilities. We want to make sure she's able to stand in front of the class, teach her mathematics or whatever she has to go for that, and make sure that she is, not short of breath doing any of those activities. So sample case outcome could be our 32-year-old female over here undergoes a 6-week program. Some studies suggest that, improvement could be as soon as 3 weeks, but 6 to 12 weeks is a typical rehabilitation timeframe. And these will all improve her 6-minute walk, reduce her dyspnea and fatigue, enhance her daily activity, and return to work readiness.
Thank you. Next, we'll have our students from the College of Nursing, please, if you come up.
Hello, everyone. We're representing the College of Nursing, the graduate division. I'm Marian.
Hi, I'm Kelly.
All right. So let's get started on how we can help Sandra and how the College of Nursing can contribute to her care. Okay, so let's start off with the role of the APR Ed. So we do a bunch of different things. First off, we are licensed healthcare providers, providing care at the highest level. We do a bunch of different things. Like I said, we can diagnose and treat. We help with pain management. We provide individualized patient care. We are promoting health and prevention. We also collaborate and we're communicating with other specialties. We also teach our patients and how we can educate them. And we also advocate for them as well. So risk factors and social determinants for Sandra. As you guys have heard previously from all our other colleagues, she has a bunch of different risk factors, which includes her ethnicity. She's of Jamaican descent. Her medical history includes that she has sickle cell disease. She's postpartum. She previously had a C-section, which had complications. She had placenta previa. She had a pulmonary embolism, a PE, also with the prolonged bed rest, which didn't help at all. As for social determinants, she's a Black woman, she's an immigrant, very limited support. Her husband also works long hours, late at night. She lives in a 2-story walk-up apartment. She teaches for a living. She was having some insurance issues where she wasn't able to get the correct support that she needed, which contributed to fragmented care. Okay, so let's look at her physical exam. So she's a 32-year-old female, presents with worsening shortness of breath and fatigue. And so she presents to us when she's 6 months postpartum, and she has a history of sickle cell disease and then also the pulmonary embolism. At 6 months postpartum, so we see her, she has dyspnea, she's consistently tired, she's not able to keep up with her baby at this point. For her vitals, we're assessing if she has any tachycardia, hypoxia, any hypertension, tachypnea, and fever. For cardio, we're looking at what's going on there. She doesn't have any significant murmurs at this point. For respiratory, it's clear to auscultation. When we move down over to abdomen, it's non-distended. As for her extremities, we're looking to see if she has any peripheral edema, which she doesn't at this time. And then also, we're looking for functional status. And she complains that she's completely winded with activities, even taking care of her baby. So as for her annual visit, which was 12 weeks later, generally she's still tired all the time. She's still having shortness of breath, and this is without not really doing much. For her vitals, she possibly has low O2 saturation with exertion and on exertion, and then she's also having increased respiratory rate, okay? As for cardiovascular, we're seeing to see if she has any distension of the jugular veins here and if there's any abnormal heart sounds. For respiratory, she's still having labored breathing, and she also has a pulmonary murmur. We're moving down, and for abdomen, we're seeing if there's any possible ascites. For her extremities, we're also seeing if she has any peripheral edema. We're reassessing this. And then for functional status, she's not able to perform some of her ADLs, so this is affecting her lifestyle. Okay.
So us as NPs, similar to the PAs, we do these assessments. We are able to diagnose. When we think of diagnosis, we are always considering what the pertinent positives and pertinent negatives are that point to or away from a specific diagnosis. So she clearly has multiple risk factors and symptoms for this diagnosis. However, it's noted that for a definitive diagnosis for this particular problem, you need some scans like a ventilation perfusion scan or the right heart catheterization that go slightly beyond what our scopes would be as a family NP or women's health NP. So that's where the importance of referral comes into play. So when we're looking at management, initially, of course, we want to be referring to cardiology, pulmonology, right? This is a complex condition that requires a lot of interdisciplinary monitoring. And she's going to be started on anticoagulations. Now, it might be the specialists that are actually prescribing those medications, but us as the NPs that deal with her mostly outpatient would be doing a lot of the medication reconciliation as well as the education, and in the long term, ensuring adherence. Same thing with the recovery. We're referring to PT and OT and ensuring that she's actually compliant with that treatment plan. But importantly, we need to consider what factors could be creating issues that she's not able to comply. So, for example, she's an immigrant, her husband works nights. Does she have social support? Does she have someone to watch her child when she goes to these appointments? Do we need to involve social work to assist with childcare? Things like home care needs. If she has to go up the 2 flights of stairs every day, does she need a portable oxygen device just to help her going up and down those stairs, especially during the recovery period? And most importantly, us as the NPs want to make sure we're really focusing on patient education. So educating her both about the medications. For example, the treatment for this particular diagnosis is the direct oral anticoagulants. That's like the Xarelto, the Eliquis, and that is for life. Typically, these patients are on these medications for their entire life. So they're not compatible with breastfeeding. She just had her first child. Is she still breastfeeding this child? Is she planning on having another? These are things that we need to make sure we're educating the patient about. We also have to focus on our education of warning her of what risks there are of disease recurrence and what she can do to help prevent disease recurrence. So additional risks is estrogen encourages blood clotting. So that would be if she chose to go on birth control after this child, it cannot be an estrogen combined contraceptive. It would have to be progesterone only. But she's also at risk if she ever gets pregnant again. And then to prevent disease recurrence, she needs to make sure she's doing little things just to prevent clotting, like wearing compression stockings, regularly walking, engaging with that PT follow-up, and of course, making sure she's complying with her medications.
Thank you.
Thank you. Okay, last but certainly not least, we're going to have our students from the School of Public Health. If you can please come on up.
Good afternoon, everyone. So we're here representing the School of Public Health. So I am Dulce, and I'm accompanied here by Anita and Asha, and we're presenting public health considerations in case study. So to start off, I included this picture here to get us thinking what public health is. So when I see this picture, I see someone holding their hand, letting someone's hand. And to me, public health means taking care of others, looking out for others. But to give you a more precise definition, according to the American Public Health Association, public health is a science-based and evidence-backed field that promotes and protects the health of all people. And so on that note, public health connects with many healthcare disciplines. And so to start off, physicians, they help with surveillance and reporting of diseases, disease prevention and early detection, screenings and vaccines, integrating population health data into clinical care. Nurses help with the chronic disease management and prevention programs, community health education and outreach, and the implementation of vaccinations and screenings. We can also see mental health practitioners addressing mental health and substance use disorders, community-based prevention and intervention, integrating mental health into public health initiatives. Midwives improve maternal and infant health outcomes, prenatal and postpartum education, and address disparities in maternal care. For OT and PT, injury prevention and rehab programs, promoting mobility, healthy aging, supporting disability and chronic condition management. Nutritionists, promoting healthy diets and preventing nutrition-related diseases, developing community nutrition programs, and addressing food insecurity.
Okay, so we're going to talk about the case study highlights. Sandra is 32 years old. She's originally from Jamaica. She has a history of sickle cell disease. A year ago, she had a C-section for placentia previa with her first pregnancy. She suffered from a pulmonary embolism during hospitalization from a cesarean infection wound. She started warfarin therapy, but that was discontinued after 90 days. 3 months later, she still experienced fatigue and shortness of breath. But when she was referred to a pulmonologist, she was told not to worry. 6 weeks later, at a routine annual physical and cervical cancer screening, she informed the healthcare provider that she could not lift her toddler or fold laundry without shortness of breath. After carefully reviewing her medical history and diagnostic tests, Sandra underwent 4 balloon pulmonary angioplasty procedures to open up the blood vessels and to restore lung perfusion. Once her symptoms began to improve, she was cleared for physical and occupational therapy.
So Sandra's case study highlights various interests of public health. First being that she has sickle cell disease. In the United States, majority of individuals diagnosed with sickle cell disease are of Black or African American descent. Pregnant women with sickle cell disease were more likely to experience complications such as preeclampsia, pulmonary embolisms, and postpartum hemorrhaging. They were more likely to require cesarean delivery. Sandra is also an immigrant woman. She was from Jamaica, and immigrant women in the United States are at higher risk for poorer maternal health outcomes due to barriers to access of adequate health care. And these barriers include a variety of things, including language barriers, lack of general knowledge of the American healthcare system, as well as other factors. Racial disparities in the United States also play a role in Sandra's health outcomes. According to the CDC, Black women in the United States were 3 times more likely to die from a pregnancy-related cause than their white counterparts. Studies have found that Black women were more likely to suffer from pregnancy-related morbidities than white women.
Okay, so looking from a public health perspective, I just want to zoom out a little bit because we talked a lot in detail about what we would do for Sandra specifically, specific exercises that might be useful. But when we look at public health, we want to zoom out and see what groups are Sandra a part of and what barriers is she facing. So one thing that we can talk about is her social and neighborhood environment. As many groups mentioned before, she's in a 2-story walk-up, which is increasing her physical burdens while she's symptomatic. Additionally, she's also having to care for a young child. Her partner is working the night shift, so arranging for childcare, arranging to get to her appointments, and follow-ups on time, that requires coordination, and it requires a lot more effort than you would think from many other people who are facing similar issues. In a social and community context, we're not really sure of what assistance Sandra has outside of her family, her immediate family, and if she has someone to help her coordinate her care. Yeah. So here are some recommendations that we would have for Sandra and women in her position. It would be screening for maternal postpartum mental health, recognizing the emotional burdens that come with caregiving, with having a child, and having health complications as a result of pregnancy is really important. And it's important to refer her to culturally responsive peer groups, such as Postpartum Support International's Black Moms Connect, which can give her a community of people who are going through similar experiences. Additionally, community-based support is so important because she has sickle cell disease. Connecting her to something like Sickle Cell Disease Association of America's education with peer and family support, which has caregiver resources and advocacy, can help her understand the context of what she's going through and what resources are available for her. There are also, if we're talking about Brooklyn, there's local organizations such as the Caribbean Women's Health Association, which has free resources for women, such as free postpartum doulas and care coordination that can make a direct impact in her day-to-day care coordination. When we're talking about medical and social care integration, we want to look at assessing health-related social needs. So that's transportation, childcare. Does she have to miss work in order to make her appointments? Is she having issues with medication access? There is a CMS guideline of doing screening, referral, and navigation to connect patients from their diagnosis to their treatment to any follow-up care afterwards. And since this is the School of Public Health's presentation, I want to connect this all back to public health policy because we can look at this specific case, but at the end of the day, there are more women than just Sandra who are going through very similar issues. From a public health policy, we want to look at what can we implement policy-wise that would make it easier to coordinate and navigate care, especially in a circumstance such as this where it's postpartum, right? So we have resources for women going through mental health issues postpartum, but streamlining care and connecting care across disciplines is definitely something that we can do policy-wise that will help women like Sandra in the future. So, and these are our references. Thank you guys so much.
Thank you. All right, I want to thank all of the students that presented today. Thank you all. You all did an amazing job. So after this, we do have a breakout session, but we're going to do about a 5-minute break, stretch, restroom, snacks, and then return to your tables for about a 20-minute breakout group discussion, and then we'll come back together. Thank you. If you're assigned to 13 through 16, 14 and 16 only, please go to the other room over there for the hybrid groups, please. All other groups go back to your tables if you don't mind. So there are 6 questions on each table. We're going to have about 15, 20 minutes for you all just to discuss some of the questions. They ask if there was anything that was missed, if you have any additional perspectives. At each table, we have representation from each program. So we like for you to have this inclusive roundtable discussion. If there are any thin tables, I'll come around and move you all around, but you have about 15 minutes and then we'll resume. Thank you.
Hi, I'm Dr. Smith from Physical Therapy, and I'm really excited to lead. Woo! How's everyone doing today? Come on, how's everyone doing today? Woo! Amazing. So we are so happy to have everyone here for this really exciting discussion, and we just wanted to hear from all of our groups. And so we're going to go through the discussion questions and report out. And if your group discussed something different, we would love to hear from you. So the first question: what is each discipline's role in discharge planning for this patient and client during the transition to the next level of care? Who did I? Amazing. Group 5.
Hi everyone. So we basically discussed stand up. Okay, sorry. We basically discussed what OT's role and PT's role would be in discharge planning for the patient. So we talked about environmental modifications. We also discussed what PA and public health's role would be, which would be to like refer the patient to advocacy groups, as well as different various resources that would be beneficial for patient care.
Amazing. Thank you. Did anyone else's group discuss anything different they'd like to share? Thank you. Anyone else want to share anything their group discussed differently for question 1? Okay, why don't we move on to question 2? What are your top 3 clinical, psychosocial, or environmental concerns for this patient and client? I've maybe voluntold some tables ahead of time.
Thank you. We really discussed one topic that can cover multiple issues, which is gaps, right? I think all disciplines are really great disciplines and they know what to do when they see the patient. However, sometimes the gaps exist between these disciplines. How do we get the patient from seeing the doctor, the NP, the RN, to seeing occupational therapist and physical therapist? You know, what are the issues? Is it insurance? Is it having a ride to see these clinicians? Or is it bias and discrimination? Because we do know that patients who have sickle cell face health disparities due to them being deemed as drug seekers, unfortunately. And we've seen that they tend to have higher waiting times in emergency rooms due to that. So there's mistrust, there's health disparities, there's bias, and there's discrimination. And sometimes they prevent our amazing disciplines from doing their job, which they're so good at, right? So a lot of time it really is gaps within disciplines and gaps between disciplines. And insurance is always our favorite topic to talk about, which is, you know, will insurance cover this visit? Will it cover between the time frame I can actually see the doctor, see the NP, see the OT and PT? So there's just, it really is gaps and health disparities. And a lot of the times, it's not the disease that harms the patient, but the disparities that prolong it, the issue.
Thank you. Do any other tables want to share anything additional they discussed? Okay, moving on to question 3. How can each discipline effectively communicate and collaborate to ensure the highest quality of care for this patient client?
Okay, so for this case specifically, we kind of cut it down into like 3 steps for like proper communication. Step 1, because it was primarily a miscommunication opportunity, we need to be able to kind of catch what we need to early in order to give her what she needs on time. So what should have happened is we need a clear handoff communication at discharge. She is high risk for recurrent thrombosis, so we need to monitor her carefully. We need to have her properly scheduled with pulmonology, and failure with this can lead to poor transitional care. Step 2, what we had was for primary care. She had many reports of multiple symptoms, fatigue, dyspnea and exertion, and ability to return to baseline. So again, the communication issue, we need to be able to refer her on time to what she needs, like pulmonology. There seems to be like no like urgency in her care, so we need to be able to get everything done on time. And then there seemed to be like a good dismissal of this patient and her symptoms, which violates the beneficence for her. A little bit of non-malfeasance and justice too. But overall, for her communication, what really needs to happen is we need effective and efficient documentation so that everybody is on board with her care. Because I know, like in outpatient PT, for example, we have like different EMRs, and we can see kind of what each discipline is doing. So being able to have access to all of her records, have access to everything that she needs, together would be the best possible way to give her the best care that she needs.
Thank you. Anyone want to add to that? Ooh, fantastic.
So I think one additional thing we talked about in terms of like School of Health Professionals, MPH, is in order to accurately track and make changes in the future, we need to make sure that our clinicians are able to record patterns that they see in the clinic and then raise those concerns to people from the School of Health Professions, people from health informatics, so that we can create like either devices that can assist or track those trends and then send out policy briefs about how we would want to see improvements and coordinate care that way.
Yeah, and I agree. I just as a one last point, um, when I read the case, pulmonary embolism, she had her baby and everything. All those were telltale signs within almost everyone here. They would know that there's going to be something wrong with her, and there's things in place such as health biases and disparities that didn't allow her to get the care she needed. And also from a health informatics stance, you can see that there can be data collection that can allow the systems to identify this as well. So it will be hard to ignore giving follow-up care to that patient.
Thank you. Anyone else want to add to that? Fantastic.
So yeah, so to further expound on the health informatics side, is terms of communication. We're more communication based in terms of we're gonna get to the patient and provider to talk to each other via EHR, via my chart to make sure every communication is being properly put out, and we're gonna make sure that there's no too much fatigue in terms of alerts, like just for the patient, make sure you do this, make sure you do this every 10 minutes, every 5 minutes, make sure that everything's up to date in terms of communication and technology. So yeah.
Thank you. Anyone else? Okay. Next question, question 4. What advocacy is needed for this patient, and what local and community-based resources are available, and how can they be assessed?
Okay, so we talked about advocacy and support services. For physical therapy and occupational therapy, we talked about the evaluation of getting durable medical equipment or DME into the home. It may not be possible, but we still want to evaluate also for home care, even if it's not a possibility based on their insurance. We also talked about social workers and caseworkers and making sure that they're going to all of their follow-ups, being consistent in that. And then also we did mention that 6 weeks is a very long time for an essential appointment. So we also wanted to talk about discussing with the patient the option of if there is another facility that can get them in sooner, what is the feasibility of them being able to transport themselves there, if that's something that works for their lifestyle. We also spoke about social support services, so who's providing childcare or who will be providing childcare in the coming years for their very young child. And then we also mentioned the importance of healthcare mental health care was not, it's something that's not well represented in this room, but we still need to remember it. So both postpartum depression screenings and also long-term mental health care screenings, they're going to be dealing with a long-term chronic disease. And so we need to make sure that they have all of the resources available to help them manage that mentally as well.
Thank you. Anyone have anything they'd like to add? Excellent.
Yeah, so for us, it was we discussed how care would be care advocacy would be for our would look like for each of our professions. So like for me, it would be advocating for early detection systems so that all this data can be logged in and that the patient can get alerts on this so that we can have a chance to help her early, so early interventions. And then from the PA side, it would be more care coordination. Like if it's a psychosocial issue, she would be recommended to psych or any other community that could help her out. And for PA would be the home evaluation and seeing what barriers she has physically for her home. And so it's just about looking at the patient as a whole person and seeing what they need, not just in the medical side, but also on the social side.
Thank you. Anyone else? Okay, moving on to question 5. What facilities or services exist to address any specialized needs or challenges? And how can the patient access these resources?
Hello, my name is Noah Palakos. I'm an OT student. Just to synthesize the perspectives from PA, OT, and PT, we discussed things such as cardiopulmonary assisted therapy through outpatient to support her functional status with breathing and energy levels. We also discussed home care and functional applications of exercises, such as using her baby as a therapeutic tool during daily tasks, maximizing her ability to perform childcare, looking at how she's lifting her child and proper body mechanics, limiting back strain. We also discussed the morning routine and scheduling of Sandra. Telehealth was also something we mentioned because regularly speaking to a provider through telehealth could really help support her mental status. But through this, you'll also have to address internet access as well as like technological literacy and medical recording devices such as having a portable pulse ox or incentives barometer could be really valuable to Sandra. And overall, just teaching her how to take her own blood pressure and monitoring her symptoms at home is going to be really important. Thank you.
Thank you. Anyone have anything they'd like to add? Question 5. Okay. Last but not least, question 6. What additional factors, perspectives, or interventions should be considered? What might we be missing?
Thank you. My name is Jimmy. I'm a PC student. So most of the concerns were addressed throughout the other 5 questions, but some things we noted were how does she commute to work or even just to her other appointments? That's something to keep in mind. The caregiver burden. So if it's her husband or whoever is there with her, what sort of burden are they taking on as well to help her and to assist her? And are they able to manage it with her as well? As PTs, just some other things that other interventions are scar management. She did have the C-section. So just addressing that as well. That's something that I think people don't necessarily think about, but just the changes that women deal with when it comes to pregnancy and having a child and going through those procedures. Anything that we can do to address that can help their emotional health as well. And how much of insurance is actually covered. So she had issues with the insurance, not just as far as getting a timeline to get the specialist that she needs, but we don't know how much is actually covered and how much she still has to pay out of pocket. So yeah, that's it.
Thank you. Anyone else?
You. Hi, everyone. My name is Melody Smith. I am in the FNP DNP program here. Another thing that might be missing is she is a new mother, so just asking if she has a pediatrician for the baby. We solely focus mainly on her, but also the baby is also a part of the care that we will be providing as well. And then if she does have mental health services available, or if she wants to be a part of any support groups that are out there, and then just referring her out.
Thank you. Anything else? Thank you, everyone. I'm going to turn things back over to Dr. Brewington.
All righty. Thank you all so much. I think you all should give yourselves a round of applause. Everyone did such a great job presenting, as I previously stated, as well as our roundtable discussions and conversation. I think that, well, I don't want to speak for you all, but I think that you all learned a lot today, that you were able to communicate with each other well. I saw a lot of robust conversations occurring, and that is what this event is for, as I mentioned initially. So just a few closing remarks. I want to thank the Dean of the School of Health Professionals, Dean Lewis, who stepped away for another meeting. He was here earlier. I want to thank all of the committee members of the Interprofessional Clinical Case Study event. Thank you all for meeting weekly, getting your students together, getting our PowerPoints together, assisting with today. So from the DMI program, we have Professor Lee, who I believe stepped out. From HI, we have Dr. Jumbo. From midwifery, we have Professor Condon, myself from occupational therapy. From PA, we have Dr. Saudi present. From physical therapy, Dr. Smith, College of Nursing, Dr. O'Hagan Murphy, and School of Health Professionals, Professor Trong. Can you please give them a hand? They're all in the back here, as well as and once again, most of all participating students, thank you for your time. Thank you for this day, and please get home safely.